It's my honor to moderate just going to take this off, the last session before everyone's released for dinner. And we have three excellent panelists here today, and I'll let them introduce themselves, but we have Kate Blackwell, who is from CMS. We have Navdeep Tangri from the University of Manitoba, and our own Suzanne Watnick from Northwest Kidney Centers and the University of Washington. So I'll let them say a few words about themselves and their maybe just a brief snapshot of their interest in home hemodialysis. And so with that, hopefully they'll pop up on the screen as they did for Larry. So first, Kate, maybe you could introduce yourself.
Hi, everyone. I'm Kate Blackwell. I'm the Deputy Director of the Division of Special Populations and Projects at the CMS Innovation Center. That's a really long job title, but basically what that means is that I oversee the team of people who operate CMMI's kidney model portfolio. So the comprehensive ESRD care model, the ESRD treatment choices model, and the kidney care choices model all fall under my division, as well as we have some other models in rural health. I've been at CMS for about 6 years, and I've spent the bulk of my time working on innovative kidney payment policy. I also work on disparities and some other work, but I'm very excited to talk to you today about home dialysis, home hemodialysis in particular, since home dialysis is playing such an important role in our current innovation payment models.
Thank you so much. Navdeep?
Great. So first, thank you to Jonathan and Matt for the introduction. So I'm really thrilled to be here. I'm a professor of medicine and nephrologist in the University of Manitoba in Canada. I think I'm here because I work at a center that's a leader in home hemodialysis. So my center at Seven Oaks Hospital in Winnipeg has 130 home dialysis patients just at my center. My neighbor across the hall from me is Paul Commenda, who's the Chief Medical Officer of Quanta SC, which has one of the innovative home dialysis machines. I developed risk prediction equations and treatment pathways, which decide when our patients get referred for education, when our patients get referred for training, and together, Paul and I designed our clinic education. So what I can say is that we've been able to achieve over the years a 50% home dialysis incident rate in our program, and a twofold higher 24-month survival than comparative Canadian registries. So really happy to be here and talk about our approach to care and learn from all of you as well.
Thanks so much. Suzanne?
Yeah, thank you so much. And again, to both Matt and Jonathan and everyone, the Ideas Conference for holding this session in particular, as well as all the others. Because home hemodialysis, in my opinion, is an underutilized modality. I'm the Chief Medical Officer at Northwest Kidney Centers. I've been here about the same tenure as Kate, almost 6 years now. And I'm also a professor of medicine at the University of Washington. I see patients at the Puget Sound VA. I am a card-carrying nephrologist. And I will say it has, in my experience, been a challenge at times to get a wider uptake of home hemodialysis as a modality. We do serve almost 50 patients at Northwest Kidney Centers with home hemodialysis, and our peritoneal dialysis population has really grown. Our home hemodialysis population has been maintained, but we hope very much to expand. And especially with some of the new technologies, we try to bring those in to bring patients the opportunity for options, but I think we can do better. And also, having been a training program director in the past, although a lot of fellows say they don't get enough training in peritoneal dialysis, pretty uniformly, they say that they don't have the opportunity to adequately see and care for patients on home hemodialysis, which is yet another barrier. So with that intro, I'll hand it back to you, Matt, and really look forward to the next hour.
Great. Not quite an hour, just in case anyone was worried about that. But the title of this session, by the way, is Enhancing the Uptake of Home Hemodialysis Progress and Pitfalls. I thought we'd just start with the pitfalls section. So the first question for our panelists, perhaps more for Kate and Suzanne, is what do you see as the historical barriers to the greatest use of to greater use of home hemodialysis in the U.S.? Maybe Suzanne, if you could take that first, and then after that, maybe Kate.
Yeah, absolutely. So, I already started to allude to it. We need, when people with advanced kidney disease need to hear about their options, they need to hear about it from somebody or a team that has extensive experience. And the less experience you've had, the less you can bring to the patient educational process. So as I mentioned, in training programs as it is, you have a variability in terms of who has been able to see a number. You've seen one home hemodialysis patient during your training, for example. Are you going to be able to confidently explain what some of the ups and downs, pros and cons, and how that might fit for someone? So I think that certainly is not only a current, but certainly a past barrier. Also, when things started out, in-center hemodialysis, there were not stations prior to the Medicare entitlement. And so patients went home. And if you look at the percentage of patients on home hemodialysis, it was actually relatively high percentage-wise. And that precipitously dropped as centers opened and there were stations to be filled. And so there were all kinds of incentives from that perspective to fill those stations. And certainly prior to the prospective payment system, the incentives were more aligned with in-center. So not just barriers to home hemo, but also to PD. Those certainly have advanced. If you think about all of the improvements that we've made in terms of the opportunities for patients, great, but there's still a lot more to go. So even with the prospective payment system aligning things a little bit better starting in 2011, we certainly saw the increase in home uptake take place, both with PD and home hemo, and then with the various models alongside the AAKH initiative, the Advancing American Kidney Health Initiative put out in 2019. Again, we saw increases in rates, and with COVID, you did see people potentially wanting to stay home, not having to go in center to sit next to somebody for prolonged periods of time. So all of these things increased home dialysis, but including home hemo, but we still have far to go because, again, I think familiarity is a big issue, and we need to have things that make it easy for patients. Patients may not want to be hooked up to a machine every single day. So what can we do to potentially make that fewer times per week? So again, with all the innovation that's out there, hopefully that's going to continue to increase. I'll hand it over to Kate.
Yeah, Kate, I'm curious your response to that, and also just the obvious sort of additional point is that many of the alternative payment models that have been launched by CMS have included incentives for home dialysis. So I'm curious as to your perspective on whether you feel that's working and what the future may hold there as well.
Yeah, definitely. And Suzanne gave a great layout of the sort of landscape. There are factors that are within, the direct purview of CMS as the primary payer in this space. And there are factors that live outside of our control. I'm not in the room with the patient explaining their dialysis options, but I, as a payer, can set up the incentives in the payment system to sort of guide behavior in response to those incentives. In our new models, we've tried to address some of the incentives in the payment system that we saw as leading to the place where in-center hemodialysis was the default for many patients beginning dialysis, instead of sort of a prospective look at options and patients having a real meaningful choice of going in-center or going home, depending on what best fits their treatment goals. So we've done that in the ETC model sort of directly by incentivizing increasing rates of home dialysis and transplantation over time. We've done that directly in the kidney care choices model by addressing one of the main payment factors on the physician payment side that creates a disparity in reimbursement between in-center hemodialysis and home dialysis. We've also done that implicitly in the KCC model, in that we're incentivizing value-based, or we're requiring value-based care. So if home dialysis is the thing that the patient wants to do and is going to be associated with higher quality of life, and lower costs and better outcomes, then there's an implicit incentive in a value-based care environment to assist patients who want to make that choice in making that choice. We've also tried to get a little bit out of the payment realm and a little bit into the education realm, using our waiver authority to free up some of the requirements around furnishing kidney disease patient education services, or the KDE benefit, so that there are more tools in the toolbox for providers to help educate patients in advance of progressing to CKD, from CKD to ESRD. That being said, I think, it's too early to say if things are working. Our models run for 5 years, and we'll get our first sort of preliminary snapshot about what is and isn't working in the 2 to 3 year range. ETC started in 2021, KCC started this year, so a little bit of time left to go before we get our first snapshot. But I do think we're seeing promising engagement from our participants in both the mandatory and voluntary context, and a real focus on home dialysis. One of the main lessons we learned from the CEC model is that while we saw a great improvement on quality and some reduction in costs in CEC, we didn't see any movement on home dialysis. Home dialysis rates stayed unchanged. And so that really informed our decision to focus in KCC and ETC on home dialysis in particular.
Thanks so much. Navdeep, maybe I'll turn to you. So you mentioned that in your center, there's quite a substantial proportional use of home hemodialysis. So what's different in Canada, and what can we learn?
So thank you for that. I think something is different in the sense, certainly at our center, I think we've been able to achieve this by really taking the education out of the nephrologist's hands. We recognized years ago that even in a group practice, there was up to 5-fold variation in for the same patient case mix, nephrologists having home dialysis rates versus inpatient dialysis rates. So we took the education out of the nephrologist and made it very standardized and very nurse-driven. So to say more about that, I think, to me, across Canada, the prevalent use of home dialysis is about 25%. And I'll just say I'm Canadian, so I get to say controversial things at these meetings. It's easy for me. I don't have to be part of these models eventually. So I think perhaps the ceiling with what we have today is 50%, and we're at 25 now. I think the second half of that 50 is the availability of assisted home dialysis. I think that's the next leg that gets us from 25 to 50. Assisted peritoneal dialysis with a cycler, assisted home hemo, which could be nocturnal, where you can see somebody like a tech going to 3 or 4 patients' homes, connecting them at night and disconnecting them in the morning. We have a fairly strong cycler-based PD program in our center, and we're really trying to push forward now an assisted nocturnal home hemo program, because I think there's certainly a quarter of patients who want to do home dialysis, but with today's equipment, today's machinery, can't do it themselves. They just need a little bit of help. They can manage their own alarms, they can do a lot, but perhaps they just need help with the setup and disconnect. So that's my sort of provocative thing, is to say, like, that's the next big barrier that gets us from 25 to 50.
I'm just curious, has there been any consideration to assisted home dialysis in any of the new payment models?
Sure. So assisted home dialysis is a thing that sort of comes up periodically, and every time it comes up, it sounds really exciting, and then we find a legal barrier as to why we cannot do it, given the current statute. I think, as we think about this round, as we think about future iterations of what a value-based payment environment looks like for either kidney patients in particular, or within the context of a larger value-based care system like an SSP ACO or global and professional contracting or ACO REACH ACO, thinking about waivers to allow not necessarily a direct fee-for-service payment from Medicare, but to allow a value-based entity to take some of that additional capital that they're getting from CMS and to invest it in that sort of way to be able to provide additional flexibilities to allow that to happen, I think is something that's been on our radar.
And I'm glad that you mentioned some of the barriers, Kate, because there are people who are considering how to work around or create new legislative fixes given some of the barriers that are out there. So we'll have to stay tuned on that, but I think it is something that has really come up in the last about 2 years, particularly risen to the front of people's minds if you've seen that a lot as well.
So next question that I have is, we've heard from you and from others about technical barriers to greater adoption of home hemodialysis. We've talked about some of the payment barriers, even education barriers. Are there other barriers that you all can think of that need to be addressed for greater penetrance and adoption of home hemodialysis therapies, however you define that, including the future of wearable devices?
I'll start off really briefly. I'll just comment about the structural barriers, and we think about this for all of home. So, you usually think of home, okay, you don't need to have a facility, but no, you actually do. And you need to have really competent staff who are extremely enthusiastic and are well-trained and can really champion the home hemodialysis modality for patients and help them navigate some of the challenges. It can be scary. If you are a person who is just starting dialysis and to be at home versus having a lot of support staff in a center. And so making sure, especially with staffing shortages these days, I think that is actually one of the biggest barriers that we're facing throughout much of the dialysis space in the outpatient environment, but certainly in the home environment where truly, a seasoned home hemodialysis nurse or support staff is worth their weight in gold, I think. I'll hand it over to Navdeep.
Oh, thank you, Suzanne. So I actually think perhaps one of the biggest barriers is in greater use of home dialysis is people having a stable home. I think that's a real challenge in a lot of inner city communities, and it's compounded by the fact that advanced chronic kidney disease and kidney failure lead to a tremendous loss of productivity and employment. And I think most of my patients feel so fatigued that even the executives who have kidney disease and kidney failure, cannot sustain employment. So the smaller your home becomes, the less stable your home becomes. Now you're relying maybe on less accommodating landlords and things like that. And these are really practical things that limit someone's ability to do home dialysis. And I think that until we sort of find ways to support people's employment and their financial status as they navigate the transition, the default will always sort of be in-center, because if your home environment becomes so chaotic, perhaps the in-center environment then becomes the escape. And you don't want to bring yet another thing into your home. So I think that's an important unrecognized barrier.
Great. Maybe the last question before I open it up to the audience for Q&A. So this question is really, I suppose, selfish from my perspective, is what can nephrologists do to participate in efforts to enhance home hemodialysis uptake? And what do we as nephrologists need to do to prepare for a future in which hopefully a much greater percentage of patients are dialyzing at home?
So go ahead.
Go ahead.
No, go ahead, Suzanne.
We're all so polite. We already alluded to the beginning around training. And so anything we can do to advocate and enhance training, possibly there's only so many hours in the day during fellowship. But is there a way to change, opportunities? Because I think that really is critical. But above and beyond that, you're so busy in your day. How can we have different options to present to our patients? I think, what we have to present to our patients now in terms of home hemodialysis, great. There's a certain number of patients that can utilize the technology that's there now. But I think we need more options. And so what's out there now and what we're seeing here at Ideas, for example, is going to bring more opportunity to expand the population, and expand it must. Going from 1 point something percent to maybe doubling, great, but that's still such a small proportion. And, if you're presenting to your patient and you say, would you prefer to dialyze at home or in a center? Presenting it that way, most people would rather stay home oftentimes. Yes, if they don't have the home to dialyze in or not appropriate home environment, that is one thing. Or if they're unable to do, or if they don't have helpers, all of these things are barriers. But I think more than anything, it really does behoove us to take this to the next step. And we do need the innovation, I think, to expand to an appreciable degree, just like Navdeep said, whether it's a helper or new technology to get Canada, for example, from 25% to 50%, we're really going to need to push some levers. Navdeep, did you have other comments?
No, I think you've said it really well. I think that the new technologies that are already well on the way, and so many of them have been showcased here as well, will certainly move the needle. I think they're clearly better than what's been around. And they're a leap. So which is good. I think, which is great. I do think some other innovative ways, and let me sort of coming back to the caregiver and the helper and the assisted models, other ways that we've thought about putting in assisted and putting in support for assisted that go outside of a medical worker is perhaps a tax credit or a subsidy for your own caregiver who agrees to become your person who provides the home dialysis therapy. So I think perhaps there are other levers that could be pulled to allow people to look after their loved ones at home with home dialysis. And in fact, in Canada, because it's a single payer, the capital cost of the in-center facility falls on the same payer. So in order to avoid any person on home dialysis reduces your need for a capital cost of building another unit. So we've been able to sell that a little more, but it still requires a lot of work, I think, in many settings.
All right, so why don't we open it up to the audience for Q&A. It sounds like we have a couple of questions in the chat first, and while we're doing those, feel free to come up to the microphone, people that are in the audience.
First question, nocturnal seems to be standard of care outside the US, but not as common in the US, although nocturnal seems to be associated with improved outcomes in patient experience. Hashtag not a nephrologist. What are your perspectives on this?
So maybe I can just say that my perspective is that it's really a patient preference thing. I personally don't think nocturnal is superior to non-nocturnal, and I think as long as people are getting adequate dialysis with good volume control, I think that's sufficient, whether it's nocturnal or not, and it just has to. You have to be able to sleep. If you can sleep with nocturnal, wonderful, 2 birds with 1 stone. If you can't sleep, don't do nocturnal, because then you can't sleep.
Any other comments about nocturnal dialysis from either of the other panelists?
Certainly a good option if patients. Oh, go ahead.
No, go ahead.
Certainly a good option if it's the patient preference. And to be honest, I think that leads into the next question, because there's a question about what makes a patient a better candidate for home hemodialysis versus peritoneal, and vice versa from your perspective, and what's the likely percentage use of one versus other within home. Well, we know currently that it's disproportionately a peritoneal dialysis world at home as opposed to home hemodialysis. But I would again say this is a patient-centric choice. And so but in the sense that we need to make sure that people have the education, the understanding, and have the supports so that they and their loved ones and their support system can help them to make the best choice for them. I think that is the most important factor when you think about what makes a patient a better candidate. Of course, you have to have an intact peritoneum in order to do peritoneal dialysis. So if you do not, then you would only be a home hemodialysis candidate. And if you had some absolute contraindication to hemodialysis, I'd say the converse. But again, I think, thinking about what patient preferences are is something that we need to look more deeply into, and how can we support our patients. And I think that this is where research dollars should go. I think if you're talking about, what kinds of patient reported information we're getting, this can be very helpful, because then people can see what others like them have chosen and how it's been successful or not within their life experiences.
All right, I think we have an in-person question here.
Yeah.
Go ahead.
Brigitte Schiller for Settler Healthcare. Thanks very much, Matt. Wonderful moderation and panel discussion. I have one comment and one question to Kate Blackwell. Regarding the sleeping on dialysis, we just did a summer program with interns because we actually wanted to find out what patients do when they do home hemodialysis. And not surprisingly, the majority actually sleeps to some degree or other. We're going to confirm this with a larger survey, but I do believe that nocturnal is widely underutilized and not recognized enough in the US. My question is to CMS, Blake Cadwell, if you could take state, would CMS consider to expand the definition of home? We've heard from our colleague from Canada, and we believe this certainly to be true in the US, that the definition of a stable home is sort of a requirement, a prerequisite to do home hemodialysis. In order to increase the access to home hemodialysis to inner cities, to people who do not have an extra bedroom to put the machine and the supplies in, and to keep being a patient and having a life separate. There are examples from New Zealand where community homes are equipped with machines where people can come in and do not go through the regular hemodialysis outpatient procedure. What's the thoughts on CMS with our joint passion for more home hemodialysis in our country?
Sure, and thank you for sharing that New Zealand example. That's not a model that I had heard of before. So it's always interesting to hear what's going on in other countries, since we can steal their ideas. I think the scenario being described would be a challenging one for Medicare, since there would be a medical process or procedure being done in a facility, and that looks a lot like a dialysis facility definitionally, and now we're sort of not in a home situation anymore. The thing that I do think we could see more of, and that I do think is underutilized, is self-dialysis in the dialysis center, where the patient goes to the dialysis center, but participates in administering their care to an extent. We've looked at self-dialysis in center as being a pathway to home, but it's also just an alternative to sort of your traditional in-center dialysis, where the patient is less involved, maybe less involved or less engaged in their own care, in that they're doing their own procedure or parts of their own dialysis procedure, and that can increase their involvement, increase their awareness, and make them feel more activated and engaged in their care.
So maybe you want to bring that up under the very much needed access to healthcare in our country, to consider that there is a third pillar needed. Thank you.
Any other online questions?
Question for the nephrologist from Canada. It's interesting that Canada places patient education responsibility to the nurses. Are physicians still able to answer patient questions that nurses may not be able to answer?
Yeah, so thank you. Perhaps I should clarify. My center in Canada places it in the hands of the nurses. I don't want to speak for the entire country. There are certainly variables, but in our fairly large center, we saw there was a lot of variability, and that's what I mean by education is that the classes. So there's a curriculum where there's classes related to kidney disease, progression to kidney failure, and the different modality options. Those classes are administered and run by the nurses. What we do is, in our interdisciplinary care model, is the patients, as they're approaching kidney failure, they have a visit with a nurse, a dietitian, a pharmacist, and a nephrologist at every time. Every visit is with a team. And the nephrologist's role in that team is to discuss modalities and discuss timing of dialysis start. Everything else is sort of handled by the other professionals. For example, blood pressure management, anemia management, mineral metabolism, phosphate, potassium. That's all handled by the nurses, the pharmacists, and the dietitians who are very competent at doing that. So the nephrologist and the patient together really hone in on the key discussions about, should I choose dialysis? What type of dialysis should I choose? When is the right time to start? And that's been successful for us. I mean, I think that, and I think it has the potential to be successful in a lot of different places, but it requires a rethink of how pre-dialysis kidney care is delivered.
Another question from the audience?
Yeah, me again, Steve. Your response to your question, Dr. Rivara, about what can nephrologists do? I think the most important thing for us to do is to think about every problem we see in hemodialysis daily, and then look for technologies that can help. And when we find some in the literature or with experience, then go to your dialysis center or the LDO or even the intermediary and see if they can be implemented. Let me give you a few examples. Catheter infections, the bane of existence of dialysis patients and physicians to many degrees. A little device like this called a clear guard, placed in the as your closing cap at the end of dialysis, elutes a little bit of chlorhexidine and has decreased the incidence of catheter-related bloodstream infections 75%. Now, one LDO is beginning to use it routinely as their cap. The problem, it's $2. $2 instead of probably 20 cents. I'll give you another example. For patients who are on nocturnal hemodialysis, if I had a fistula needle that many of them use and poke my finger, it would hurt. This doesn't hurt. It's a fistula catheter. Okay. 3 companies make this. Widely used in Canada, Japan, Europe, but not in the US. The beauty is overnight dialysis, if the patient moves his arm back and forth, bends his elbow accidentally, you're not going to lacerate a vein with a needle as you would with a catheter. Problem, $2 or $3 instead of 25 cents. Citrate, anticoagulant catheter locks, widely used in Canada and Europe. No risk of HIT, heparin-induced thrombocytopenia, equal effectiveness at least for keeping catheters open. Even at 4% sodium citrate, should be 7%, working on that. Not used in the US, why? Expensive. It's what's called a on-prescription drug, 503B, I think, has to be through a prescription written for the dialysis unit, and in a pre-filled syringe, it costs a few dollars. Final example, and this isn't really a dialysis product. This is a little vial called APT. It's an over-the-counter medicine, filled tetracycline, but also a whole bunch of stimulants that will improve wound healing. And it's based on the stem cell activation. Nothing really fancy, just the right combination. It's used widely for pins placed for external fixation devices in orthopedics. Pretty dramatic results. The problem here, OTC. You'll never get any insurance payment for it. So anyway, that's just a smattering. There's plenty of other things. And I appreciate all the care of nephrologists, especially for the really important things like home hemodialysis versus in center. But anything you do to improve dialysis will help your home patients. Thank you.
Thank you. So we have a few minutes left. Any other questions? Oh, another one here.
Hello, I'm Curtis Warfield, patient advocate and 6.5-year kidney transplant recipient. To ask of the question of what nephrologists can do, they can actually put into their care plan to actually talk about home dialysis. I had to fight to get home dialysis. Took 2 fistula attempts before I even found out about home dialysis. And also I would like to ask the panel, would you support with home dialysis as part of the training to have someone, be it a nurse or an assistant, come in during the first parts of a person starting home dialysis to come to the home and actually help assist until they felt comfortable with doing home dialysis. A lot of times people will try it, get discouraged because they're at home trying to do this alone, and then quit and go back in center. So would you support having a nurse or a doctor or a nurse's aide come in and help start you with home dialysis at home?
Thank you. Suzanne, you want to address that?
Sure. So thank you very much and congratulations on your successful transplant. I think it's always wonderful to hear. So in terms of coming into the home, we do come into the home. Everybody gets a home visit, but to your point, is there the opportunity to have a nurse, to have a support person be in the home? And that's exactly what, we were addressing a little bit earlier. Is there somebody that can be there for assisted, whether it's assisted PD or assisted home hemodialysis? And right now, there isn't a way to compensate for that. Would somebody come and do that without that capacity? It's something worth exploring. And I think that, it only will expand the modality, which is probably your point. The one thing that I will say that I think is very important to mention is, how are you setting up your training programs? At least making the environment where you're training as similar to a home environment as you can, making sure that you're accommodating the support person who would come to train or support people that would come to train with the patient, and accommodating the hours. Can we do home hemodialysis for somebody who is actively working? Well, let's make sure we can train people at 5 p.m. at night, for example. So we're trying to think of innovative ways to support patients through different mechanisms and to be flexible as opposed to a one-size-fits-all, because that never fits everybody. And so I think we have work to do. And I think what you just mentioned really highlights some of the work to do. So thank you very much for that.
Another question?
Yes, thank you. Richard Knight, president of AAKP. I want to thank the panel for sharing the information about home dialysis. And I also want to ask the panel, what is it that patients can do to help you? And I want, if you will respond in the context of, if we look at value-based care, then when somebody tells me this costs X number of dollars and it's expensive, I think they're missing the whole point of value-based care. If in fact we are looking to provide care to the patient that overall will enhance the quality of life and in the long term stop them from going to the hospital, allow them to be a productive member of society, I think that we need to take those factors into consideration. So I'll turn it over to the panel. And again, I appreciate your insights, because not enough patients have the opportunity for home dialysis. So this is a great topic of discussion. Thank you. I'll sit down and listen to your response.
I'm just going to quickly take a first comment and then hand it over to Navdeep and Kate, and I apologize. But so first of all, Richard, thank you so much. I'm so glad you made the trip to Seattle to come be here and experience and to ask your question. And I think you make the critical point of what is critical for the patient's quality of life? What is critical for the patient experience? Let's make sure we're always asking that question first. If something is more expensive or difficult to access, okay, but maybe it is, but let's figure that out. And I think that, again, that's the purpose of this conference. What are the ideas that are out there to optimize the best quality of care that we can provide for people with kidney disease? Navdeep, I'll hand it to you from there.
Oh boy, yeah, thank you. So again, thank you, Richard, for speaking out. And I can't provide. It's hard for me to tell what patients can do. I think the only thing I would say is that when you're not presented with all the options, do not be afraid to ask. Do not assume that your doctor knows. And doctors, if the doctor's only telling you half the options, don't assume that that's because they know what's best for you. Ask about all the options, because we're all served if everyone knew what was on the table and made the decision with all the facts. So I would say that, through continue, I would really applaud your work with the AAKP, and let's continue to make patients with kidney disease in the U.S. aware of all their options. And I think that will drive the physicians to learn more about home dialysis, to learn more about preemptive transplant, and present it to them. So I know that when my patients ask me about something that I haven't presented, it gives me pause. And the next time, I don't want that to happen again with the next patient. So I come to the table more prepared the next time. So I'll leave that there.
Yeah, and in terms of getting to those of us in the government who think about these things a lot, I would encourage you to speak up in all the venues that you have to get to the government. So you can talk to us directly. I think this came up at the end of the last panel through 1-800-Medicare. Our Innovation Center models have helped us where you can send us feedback. You can talk to the ESRD networks as your connection between your dialysis facility and us. I would also put in a plug for filling out your CAP surveys. The things that get measured are the things that matter. And the CAP surveys are the way that we've coalesced around to measure patient experience. I know there isn't a CAP survey for home dialysis. That's a thing that we're working on and thinking about to match the in-center hemodialysis CAPs. But responding to those CAP surveys really matters. I know they come often, but that's really important so that we get information about the patient experience so that we can quantitatively point policy in a direction that will better support patients. And as always, comment on rules. The ESRD PPS is out for comment at the moment, and the physician fee schedule goes out for comment every year. So please comment. We read every comment on our rules.
I think we're a couple minutes over, but it sounds like there was 2 comments on the chat that came in a little while ago.
Within home, what makes a patient a better candidate for HHD versus PD and vice versa? From your perspective, what is the likely percentage use of one versus the other within the home?
Ooh, that's not a short question. Maybe Suzanne, do you want to take that one as perhaps a closing comment?
Yeah, I think we were addressing that a little bit earlier, talking about, the main issue is to make sure that you have, you've talked with your patient, which is really the theme that we've been hearing throughout this entire session. Of course, if you don't have the capacity to do that, and there are very few barriers, but they do exist. That is an issue. And so we already know that home hemodialysis in particular takes up a smaller proportion. It has expanded and nearly doubled over the last 15 years plus, but there's a lot farther to go. And we heard Navdeep, and I agree with Navdeep, that somewhere on the order of 40-50% is probably the greatest penetration we'll see in terms of home dialysis overall. And depending on the technologies we see and depending on the successes that we see from conferences like the IDEAS conference, we may be able to see home hemodialysis capture a larger portion of that. So please, everybody who's here, make sure that you not only participate, but speak about this to others, to the kidney community, and make sure we get people engaged. That's how we can change the needle on this. And with that, I'll hand it back to you, Matt.
Thank you so much to our 3 panelists and for all the audience members that asked the questions. With that, I will turn things over to Buddy and Jonathan for the closing remarks.